I have very good insurance, but they say like the hospital charged you $7,000, but good news, we bargained it down to 5,000. And what you owe now is zero. But I know that scan was not worth $7,000 or $5,000.
Hmm.
Probably should have cost 500, but we did this on your behalf. Many people are just like, wow, I dodged a bullet, but they don't kind of get that the bullet circles around the back and hits you in the way of
Right.
high premiums next year.
Welcome to the East Anchorage Book Club. I'm your host, Andrew Gray. Today, our guest is Dr. Elisabeth Rosenthal. She is the author of An American Sickness, How Healthcare Became Big Business and How You Can Take It Back. A book which the Washington Post described as, quote, an authoritative account of the distorted financial incentives that drive medical care in the United States. Every lawmaker and administration official should pick up a copy of it. Well, this lawmaker did pick up a copy of it, and it has profoundly influenced my thinking about American healthcare. But more importantly, the book has provided potential solutions for Alaska. Dr. Rosenthal was, for 22 years, a reporter, correspondent, and senior writer for the New York Times before becoming the editor-in-chief of Kaiser Health News, an independent journalism newsroom focusing on health and health policy. She holds an MD from Harvard Medical School, trained in internal medicine, and has worked as an ER physician. For over a decade, she has been responsible for a popular segment on National Public Radio that you may have heard called The Medical Bill of the Month. Dr. Elisabeth Rosenthal, welcome to the podcast.
Thanks for having me.
Let's get started by learning just a little bit about you. How did you decide what you were going to do with your life?
Oh, gosh. I come from a family of doctors. So when I wasn't quite sure what to do in college, even though I loved writing, being a doctor seemed the obvious thing. So for many years, I, in a very disorganized way, jumped back and forth between going to med school, writing on the side, being a resident, writing on the side, taking some time off of medical school to work for a year for a magazine. And ultimately, I worked as an ER doctor, in part because I'm an adrenaline junkie, and in part because standard ER practice is 3 days a week, and I had time to write. And then it was a fluke that I became a full-time journalist because it was partly working in an ER in New York City. You see all the problems in our healthcare system, and that was in the midst of the HIV/AIDS epidemic. It was a really hard time. And I thought at some point, man, I can treat people one by one, or I can say this system sucks and we need to do better. And in fact, that was around the time of the Clinton health reform effort. Now I'm going to sound like a total dinosaur because we've been trying to make this system better for so many years. And I'd done enough writing for the Times that when that became a thing, they said, do you want to come on staff? A bunch of things had happened. I had my second kid. New York State had said, if you want to work in an ER, you have to be ER boarded. And I was internal medicine boarded, so I would have had to do some grandfathering stuff. And so I went over to the Times to cover the Clinton health reform effort. And I just thought, I'll do this for a year, it'll pass, and then I'll go back to being a doctor part-time. And of course, it didn't pass, and I got hooked on journalism. And it was really the idea that you can make more of a difference writing about these things than you can being frustrated one patient at a time. And the system wasn't even that bad then. It had only started to become commercialized. But even then, I saw the tip of the iceberg and I saw where we were going. And boy, 30 years later, it's just so much worse. Even since I wrote my book, the frustrating thing is, which was in 2017, I saw all these problems with our commercialized healthcare system. And I thought, I'll write this book and everything will get better. I'm the eternal optimist. People will open their eyes and say, that's why medicines cost so much. But in fact, things have just gotten worse. And now we see things like private equity marching full force into healthcare, which is just so alarming. And that I just tip to in the book. There's so much to be done.
That's the way I came to know you, was through your book, An American Sickness. You're a very gifted writer, and you tell these stories very fluently and effectively, but there's so many problems. It's overwhelming. You make it to chapter 3 and you think there's so much to be done in these first 2 chapters. How could there possibly be more? It just feels almost an unclimbable mountain to try to make a difference. And, the book opens with you quoting the professor from USC, Glenn Melnick, saying that it's so dysfunctional that the only solution is to blow the whole thing up. You're my 6th or 7th interview about this issue in the past couple of months. Everyone has said that they just don't think that's possible. That the idea of creating a completely new system and throwing out the old system is just not practical.
Yeah, I think politically that's probably true. That's essentially what Medicare for All is, right? It's just throwing away all the layers of our system and putting everyone on Medicare, which isn't perfect, but people generally like it. We don't get a lot of complaints. We run this bill of the month project with NPR, and we don't get a lot of complaints from Medicare patients. So the Democratic candidates, until this election, have always floated it in their range of possibilities, not usually endorsing it, but usually more of a public option kind of thing. This time everyone's silent on it. I think because abortion and access to women's health is the healthcare issue of the moment. But it's lurking there in the background. What are we going to do? Because I'm always surprised when we hear all these people getting on the radio and television saying, I feel poorer because gas prices are $1 higher. I want to say, it's not gas prices, it's your insurance, it's your healthcare costs. That's why everyone feels poor. And we got to do something about it. And I think you're right, politically, it's not practical to blow the whole thing up. So we have to do our best to chomp around the edges. And that's happening. It's helping. But as you say, the mountain is so big and we're pulling off some pebbles that have fallen down to the bottom. But it's a start. We've broken some barriers federally and in the states that were maybe unthinkable 6 or 7 years ago.
I'd like to talk about your New York Times article from 2019, which talked about, and this is after you've written the book on American healthcare and its issues. Your husband had a really bad bike accident, and you detailed how you personally experienced so many of the horrors of the American healthcare experience.
Sure. Andre was in a bad bike accident. He broke 6 ribs and had a collapsed lung and a host of other little more minor fractures. And he was rolled into the hospital pretty much unconscious. And the first thing I got was like, oh, here, sign this iPad, right? And I'm like, what am I signing? I've got my antenna up. I know my husband is really ill, but, I'm like, what am I signing? And they're like, oh, it's just some disclosures and financial forms. And I'm like, I'm not signing this iPad. And what am I? And they're like, lady, your husband is like lying on a stretcher, unconscious. What do you just sign? And I'm the kind of pain in the rear patient who says, I want to see those forms because I know the financial form says I may be treated by some out-of-network doctors and I agree to pay for them. And I don't agree to pay for them. I think I ultimately got the form when I crossed out that line, which who knows if that's legally binding, but at least I could argue. And then he was in the hospital for, I can't remember, it was 3 or 4 days. And there were just so many things that happened that I'm like, gosh, this would be fraud if it was any other business.
The neck brace. Talk about the neck brace, because I find that one completely egregious and terrible.
Oh, yeah. He was brought in on a neck brace because there was always a worry that his spine had been injured, which it wasn't. And after they did the x-ray, they took off the neck brace and they charged us for disposable medical equipment. You remember in the article.
Yeah, it's $319 was how much they said the cost of that neck brace was. Insurance paid $215. You were billed $24 for your quote patient responsibility. But there's no way that plastic neck brace that was on for an hour cost $319 to anybody.
Except to an uninsured patient who's going to have to pay that whole thing, or a patient with a high deductible plan will be on the hook for that. And I was like, we didn't even get to take that home. And then there were things like he had a small finger fracture and he had a splint on it, and it was digging into his fingers. So we had to go back and they looked at it and they cut down the splint and put some tape around it. And that was billed as surgery. I'm like, wait, doesn't surgery have to be like on a person? It's not like cutting down the end of a splint. There were just so many things. Someone would come into the room, and he's been hospitalized recently for something else. And someone comes into the room and says, can I walk with you down the hall? And you think this is a nurse helping you. And guess what? That's going to be charged as a $500 physical therapy session. There was just like on, and my head was spinning. I was so angry, but my husband was sick. I wanted to scream each time this happened. I wanted to say to my insurer, that was not surgery. But like most people, life goes on, your husband comes home, and my insurance covered most of it. So I didn't do what I know I should have done, which was to fight every one of those 10 battles. But there's so many of them.
One of the ways that Alaska tried to combat some of the lack of transparency is that we passed a bill a few years ago that required the posting of the price of 10 most common procedures. But here's why it didn't work, in my humble opinion. Because when a patient shows up at an urgent care, they cut their hand while washing dishes or something. They're not going to comparison price shop. They want their hand sewed up. And most people, their insurance, even if it's Medicare or Medicaid, is going to pay to have their hand sewed up. So there's no real motivation, nor is it practical to do price comparisons and those sorts of situations. And so I think it put the burden on the patient to make better price decisions. At the time that law was being passed, it seemed very reasonable that this was really going to transform the way we do medicine in Alaska. It has had zero impact. Zero.
Yeah, and I think part of that is what you're saying. It's so unfair to expect people when they're sick to comparison shop. This is not like a loaf of bread, it's your health. I think it is a good thing to have passed, to have that kind of price transparency, because there are some situations where, for example, if I have to get some routine blood work done, I can check what LabCorp and Quest and my hospital are charging for that. I should be able to, and say blood work is blood work, or an MRI is an MRI, and go to one that's cheaper, particularly if I have a high deductible plan. So those kind of elective things, it should work. People, A, aren't trained to do that, and B, when prices are listed, they're often not listed in a way that's shoppable, that's very easy to compare. Like, really, to do that, you have to call every different x-ray place and every lab and say, what do you charge? So I'm all for transparency, but look, the Trump administration forced every hospital to list on its website its charge master, which in theory shows the price of everything they do. But it's in a computer readable format, like it's all in medical codes, it's hundreds of pages. If you're going to have a hip replacement, good luck figuring out which of those thousands of codes, like which hip will be used, which screws will be used, how long you will be in the recovery room. There's just no way. It's unfair to ask people to comparison shop, and practically speaking, there's no way to do it for most of the things we need in medical care.
You talked about this happening in California, when California, prior to the Trump administration, made its charge masters, all the hospital systems had to disclose them. Every hospital system did it in a different way. So, as I understood it from your book, making it really impossible to compare things. If they're using different abbreviations, if they're using different order, there's no uniformity in terms of the way the charge master is published. So
Right.
the goal was to satisfy the statutory requirement while remaining as obscure as possible.
Right. California, for that reason, used to be the gold state for medical reporting because they did that. Because at least if you're like me and you're willing to sift through hundreds of pages for a code, you might be able to find out like some little interesting things like what they're charging for that neck brace or the little tube of glue. So you can find some things. But then when the Trump administration did it nationally, they all had to do it and they all complied in different ways. And it's often in some corner of their website that you can't find. They've just made it as unuser friendly as possible. So I think, yeah, transparency is a good thing. And there's all these people who believe all we need to do is make prices transparent and everything will be solved. And of course, it's a baby step. It's not bad, but
It's interesting because when we had a borough in Alaska passed this ordinance last summer that required city employees on city insurance to go to a hospital in Anchorage as opposed to the hospital in Wasilla, which was most nearby to them, because they were stating that for these common procedures, the cost could be up to 9.2 times higher at that local hospital as opposed to the hospital they were recommending in Anchorage. When I interviewed the chief medical officer of Alaska, her eyebrows went up and she said, I don't know how they know that because we at the state don't know that. Like, we don't know what the negotiated prices are for those that the insurance companies are paying at the different hospitals. And so that's like the top line possible bill is to outlaw non-disclosure agreements between insurance companies and the different hospital systems, doctors' offices, clinics, as imaging centers.
Sure. A year later, the Trump administration said they had to publish the rates they get from different insurers. But again, in a way that's computer readable. And I'm not a computer and you're not a computer. And yeah, there are like computer people who've now taken those and like everything in American healthcare will sell companies back the information that should be public and user friendly. But that's why everyone's feeding it the trough in healthcare. And it's frustrating and it's sad. And patients are ultimately the ones left holding the bag. And I would imagine what they heard was was a lot of patients were being charged a lot at that hospital.
Mm-hmm.
Maybe because that hospital has monopoly power and the insurer agreed to it. Who knows? But it should be more transparent. And we see a lot of this. Okay, we'll give you insurance, but we'll give you a plan that's for Mount Sinai, but not Mount Sinai in Manhattan, the satellite hospital. And so it's so confusing for patients and so absurd. Like I can't even.
I want to bounce back to your husband's bike accident. And you mentioned the physical therapist stopping by the bed. In the article, you state that the physical therapist asked 3 or 4 questions, and then you were billed $646.15. And in that, it said that the physical therapist had been there for 30 minutes. He was not. That he had walked Andre 10 steps. He had not. Basically, the average patient who's getting tons of bills in the mail isn't going to do the deep dive and look at the fine print and see actually what is being billed for to be able to push back on that. And again, I think part of it is because the person getting the bill isn't going to pay $646. Their insurance company is going to take care of most of this. And furthermore, I want to throw it in there. You also got billed for follow-ups from the PT, from phone calls to your home. They billed those as visits when they were basically asking, is he well enough to move around yet? No, he's not. And they billed you as a visit.
Yeah. Yeah, it was very frustrating. And I think one of the things I always tell people is ask for an itemized bill. I know it's a pain in the rear because a lot of people now, and it should be illegal. How would this work if it was a contractor redoing a kitchen rebuild $20,000? Not saying what was what. And in healthcare, you get those bills now. It just says a gallbladder operation or pay this. So I tell people to ask for an itemized bill. And the reason is because you can get mad at insurers all you want for paying these, but your insurer doesn't know what happened in that room, right?
Right.
Doesn't know what that visit was.
And you make the point that since they're paying out millions of these, like how would they ever find the time to do deep dives into every bill to see if these things really happened?
Yeah, you care a lot about your bill. There was one uh, patient I saw when I was working at the New York Times. I worked with who was billed for an assistant surgeon on his shoulder surgery for $119,000, and he'd never met the doctor that who assisted in the surgery. Wasn't clear the doctor was necessary, but his insurer paid. The way Blue Cross Blue Shield worked at the time is they paid the check to the patient to give to the out-of-network doctor. And this guy, Peter, got it and said, I'm not sending this to this doctor. I never even met the guy, and I don't know what he did. And Blue Cross ultimately, like the doctor sent him a threatening letter saying, hand over the check. And I called Blue Cross to say, like, why do you pay these things? And it's exactly what you said. They're too big to care about you. Any one case, they'd have to investigate, they'd have to get the hospital records, they'd have to sue the doctor probably. So it's just easier to pay and raise premiums and co-pays and co-insurance and deductibles every year.
Which incentivizes those assistant surgeons who aren't even in the room to bill for $119,000. That's almost double the median annual income of the district I represent. It's just an insane number.
Yeah, and the surgeon himself got $6,000 from the insurer. Probably, right, maybe even a little too low for a complicated surgery. But so I think it's the notion that your insurer is in your corner, which they try to foster. I get these explanation of benefits from Cigna. I have very good insurance, but they say, like, the hospital charged you $7,000, but good news, we bargained it down to $5,000, and what you owe now is zero. And I'm like I'm supposed to be happy, but I know that scan was not worth $7,000 or $5,000. Probably should have cost 500, but we did this on your behalf. Many people are just like, wow, I dodged a bullet, but they don't kind of get that the bullet circles around the back and hits you in the way of high premiums next year.
One of the solutions that's offered in the book is to incentivize well-priced, all-inclusive packages for common procedures like joint replacements, cataract surgeries, colonoscopies. And you use CalPERS, the CalPERS system in California, which created reference pricing, which basically looked at what the prices were for these common procedures across the hospital systems and didn't offer the lowest price. I think that's important. It said if the price is between $10,000 and $100,000, we'll make the reference price $30,000. And that's how much the total amount can be. All inclusive, like from prior to arriving at the hospital through physical therapy afterwards if required. Yeah. I have talked to at least one person in the administration here about they love that idea. I'm not sure how to require it, but I'm looking at it.
What CalPERS did, and in response, CMS, their innovation center, did a whole project on doing package pricing for some common procedures. And it was all a great success, right? It worked really well, but it didn't catch on. And why didn't it catch on? And the notion was, sure, you can pick a hospital that does it for over $30,000, but you're going to have to pay the difference if you do. And it worked like magic. People got hip and joint replacements and colonoscopies at a reasonable price. And the problem is that what all the things that can't happen when you do reference pricing and bundled pricing. The anesthesiologist can't charge an arm and a leg. So it's who's gonna back down from their high prices. Because it was funny when California did it, because they did a reference price of somewhere around $30,000. And all these hospitals that normally charge way more were like, oh yeah, we could do it for that. But the way we've disaggregated pricing, you have to get like the anesthesiologist and the surgeon and the hospital and the pathologist to all agree who takes a cut in their. Everyone wants to make sure their piece of the pie remains high, and no one's really willing to give. So it wasn't that it didn't work. It was that it didn't work for the doctors and the hospitals, as well as just being able to charge piecemeal for everything that goes on. If you reference price a hip replacement, you can't charge for the oxygen by the bedside and the 45 minutes in the recovery room, which is actually, I'm a former physician, it's usually 2 hours. And half of it is because the surgical team is eating dinner, not because you need a recovery room. So a reference price eliminates that. And by the way, in the 80s, many states had something called DRG pricing, where for things like a pneumonia, they would say, this is what a hospital will get. It's this amount. And some people will get out easier and you'll make money. And some people will stay longer and you'll lose money. And it was the law in about, I think, 8 or 9 states. And eventually, the hospital associations and the state medical associations brought it down because people like stealing it from patients.
Two things. Number one, Oklahoma, you mentioned the surgical center that was guaranteeing operations, offering sort of a warranty on your operation, that if there was a need for a repeat surgery or some sort of, additional care, that it would be free of charge. It would be included. The same way that if you bought a brand new car and a week later it broke down, you wouldn't be expected to do an expensive repair on the car you just bought. And I think this would apply that when you got charged for altering the splint on his finger, that I'm sorry, but if the splint is pinching the finger, no one should charge for that.
Right. And bundled pricing usually bundles in some period like 30 or 90 days post-surgery. If you have to come back, it's included in the bundle. But again, hospitals don't like that. I get really nuts when people acquire infections in the hospital, right? MRSA, and they have to come back in and be treated for that. Who's responsible? The hospital for that. But somehow every medical encounter is paid individually and at a high price.
Right, which incentivizes poor medical care. If you're going to be able to charge more for a hospital-acquired infection or for a revision of you did a poor job of stitching up the knee and it comes undone and you have to re-stitch it, you're going to charge again. Like that's absurd.
Yeah. One of my tips to people, but it may be one of those, don't do this at home. In the old days when I was a doctor, if you put in stitches, they were taken out for free. Now at a lot of places, those appointments for removal of stitches are not free. They'll try and charge. So I buy a little suture removal kit on Amazon for $3. And most of the time it's fine. There's no magic to removing stitches.
Full disclosure, I work at an urgent care on Fridays. I'm a physician assistant, and we charge it as a nurse visit to remove sutures. But it's a misnomer. It's not a nurse. That's a medical assistant who I don't want to I love the people I work with, but some of them just started 2 weeks ago and are 19 years old. You could do as good a job.
Right, exactly. Sutures. Exactly. I never want to recommend do-it-yourself options because you should be able to get this within our healthcare system. If it's going to be another $200 charge, like do it yourself.
I will say one other thing. My very first job out of PA school was at an HIV clinic in Beverly Hills. And what happened at that clinic, it was 2013. And it is important to know because by 2013, we had antiviral drugs that were once-a-day pills. And the viral load was undetectable. So for all intents and purposes, when your viral load is undetectable, we were a primary care clinic. If somebody had strep throat, we treated them exactly the way you would treat anyone else with strep throat.
Sure.
But the clinic required us to bill as complicated patients because they had HIV.
Yeah.
We were able to upgrade every encounter because it was complicated because they had HIV.
Yeah, and that's something that I always, another reason to look at your bill and see, no one bills level 1 or 2 visits anymore, right? It's even though many visits are level 1 or 2,
Right.
hospitals have better billing courses, not better, not meaning better medicine, but like how to bill more for that patient encounter. And it gets very creative. We learned from one of our patients at KFF Health News and this Bill of the Month project we do with NPR about something called an emergency department delivery room, where, this woman told us she was 9 months pregnant. She walked into the labor and delivery department. Someone checked her cervix to make sure it was dilating. And suddenly, when she looked at her bill, there was an emergency department charge. And she was like, I walked through the emergency department, took pictures, but no. And what it was, checking her cervix, they'd managed to rebrand as an emergency department, which it was not. It just wasn't. There's a lot of false branding, doctor's offices where you get a charge for a hospital facility fee just because the hospital has bought the practice. But it is not a hospital, and that shouldn't be allowed.
You wrote about Andre needing a refill of his pain medication, and the doctor suggested that you meet in the emergency room because his clinic was only open from 8 to 10:45 a.m. on Mondays. So you met in the emergency room for a refill on a medication, and you were charged $1,330 for an ER visit.
Yeah. Yeah, my kind of mantra in life is stay out of the emergency room if you can, because we also in our Bill of the Month project have patients who went into the emergency room, registered, and waited as many people do for hours and hadn't been seen, so they left. But that act of registering cost them $1,400, and they were like, wait, this emergency department failed me, and I have to pay $1,400. And I think patients get this coming and going, and it's really not fair. And you mentioned something about estimates. Another thing we hear, and another thing I hope legislators can do in parts of the country, are binding estimates. I have so many patients who like, oh, I did what you said, and I got an estimate in writing, and it says binding estimate, and it was $4,000. And then I get a bill for $12,000. And they call the hospital, as we directed them to do, and say, I have an estimate of $3,000. The hospital says, oh, that's just an estimate. Huh? Like, how is that a binding estimate when you're off by a factor of 4? That's not.
Because I think because the surgeon, the physician, the facility is motivated to make every patient special, every patient complicated, every patient needed something extra.
Yeah.
And I think, how do we remove that incentive to overcharge? Because it is an overcharge.
Yeah. And it's false charges. It's not just overcharge.
Right.
It's often charging for things that weren't done. And your insurer will not care about that and will not know about that. So how do you do it at a legislative level is challenging. But I think, requiring binding estimates, make the hospital go through the trouble of arguing with their doctors and anesthesiologists. For me, one basic thing, which I think, oh my God, why is this so hard to do? And I know because of the groups involved why it's so hard. But I had a thing where my son needed a hernia operation. It was an in-network hospital, an in-network surgeon. And since my antenna are always up, I'm like, oh, will the anesthesiologist be in network? And they were like, we don't know. And I'm like, hey, you know which of your anesthesiologists takes Cigna. You assign the anesthesiologist. Get me an anesthesiologist in network. So I do think there's something to be said, and there's going to be tremendous pushback for medical groups because everyone thinks they're underpaid. It's a
Right.
funny thing in the profession that if it's an in-network hospital, everything that's done to you in that hospital should be in network. They should guarantee that. I would go to a hospital that had a sign up outside saying, everyone here is in network. But that takes hospitals arguing with the anesthesia providers and the surgeons because out of network is good money. And they need a plastic surgeon to cover the ER. Most plastic surgeons don't want to be in any networks.
And that
What you're trying
happens.
to
If
do.
somebody's eyelid is split open, the ER doctor doesn't do that. You call plastic
Yeah.
surgery. Although I worked in the ER in California for a few years, there are plenty of plastic surgeons who would say, just send them to my office tomorrow. It will be fine. No matter how crazy it looks, they'll say, just send them to my office tomorrow. But I bet they charged for that phone call in which they said, send them to my office tomorrow.
Yeah.
Um,
It's hard and it's sad and it's hard to fix.
I want to bounce back real quick to talking about billing for a level 1 or a level 2. So many of the visits that we see in urgent care are folks with an upper respiratory infection that do not require antibiotics. They do not have a fever. They do not have pneumonia. They're there because they're like, this cough has gone on for more than a week. And so I figured I should come in and get treated. And the gold standard medical care is stay hydrated, get plenty of rest, take over-the-counter medication as needed. That's what you do. So you're basically telling these folks who are going to be paying for this visit in cash, they do not have insurance, you're sending them home with nothing. That's one way that they think of it. And it's $186. I know how much that level 2 fee is going to be at the desk. I talked to a nurse practitioner once who did not work in urgent care, and she said, why don't you do no charges? I was like, I can't no charge my whole patient panel for the day. I can't be on shift all day and just do everyone as a no charge. So the lowest level that I'm allowed to charge is a level 2, and I do that. But there's far too many visits to urgent cares and ERs that didn't need to go to the urgent care or the ER, that there needs to be some sort of education plan for the population, some sort of nurse hotline.
Yeah. Yeah, no, and I think the problem is when you go that route now, and I've said, oh, this would be a good idea to cut. Now, there are telemedicine appointments, and they're good. You could screen people there or phone calls, which are billed. So everything is billed.
Right. There's no escape.
There's the telemedicine appointments, which should be ideal for those kind of things and should be cheap, are billed at the same price as in person often and with a facility fee. I'm like, how is there a facility fee when I'm sitting in my bedroom talking to you? Like, where's the facility? I think the notion is that every time we try to make things smarter or better for patients by manipulating the cash incentives, the healthcare industry is very agile. It finds a way around it or to exploit them to make more. And at some level, I applaud the federal government for finally saying, we're just going to negotiate some drug prices because that's gotten out of hand.
I want to talk about that. You wrote about in Maine, when Maine licensed some Canadian pharmacies so that patients could order a 90-day supply of their medications from those Canadian pharmacies at Canadian prices. And Big Pharma caught wind of it and basically squashed that plan. We've seen Ron DeSantis in Florida this year is moving forward, and it seemed that both the Trump and the Biden administrations were signing off on the FDA approving these plans to be able to import medications from other countries at those countries' prices. Obviously, I love that.
There was just a JAMA article about how to do it, and they recommended a good kind of screening middleman for these drugs called pharmacy checker. It's a medical association telling you how to essentially illegally import drugs from Canada because there still is somewhat a gray area still. But I applaud a number of states have done legalized importation.
Seems like you've got to get buy-in from the country that you're importing from. What some of the pushback for importing from Canada is Canada has said, hey, We're a smaller country than America. We can't provide all the medication to America.
Sure, Canada doesn't love this. And in fact, Pharmacy Checker, I know, sources drugs from other countries as well, but all screened. And our drugs are made in other countries.
Right. That's what's so ridiculous to me.
Yeah, so Florida's done it. Governor DeSantis, one of the most conservative people, but this is why I say healthcare is a pocketbook issue. It's not right or left. And a number of other states have done that. They've done drug pricing boards. I think that's a new thing I've seen in a number of states where they say, this is not affordable anymore. We're going to set the price for you. So doing it at a state level, what they're doing at a federal level. And we'll see. I know Colorado has one. We'll see how they stand up to legal scrutiny, because I'm sure the drug companies are going to be like, you can't do that. It's our First Amendment right to charge what we want and advertise as much as we want. And so I think there is a lot of movement at the states. There's also movement nationally to do something called march-in rights, which may be effective, where you say, if there's a drug you can't get in this country, and they don't specify the reason, you can, the Congress and what I think it's CMS can allow large-scale importation from other countries. And we actually saw this for a little while with the weight loss drugs, with Wegovy, not because they were too expensive in that case, but because there was genuinely a shortage, because everyone wanted them all of a sudden. Now there's no shortage. So what happens to all those pharmacies that were allowed to make them and sourcing from overseas? But margin rights are an interesting idea, because there are those in Congress who say price should be thing. If the price is so high that it's unaffordable, that's the same as having a shortage. And so we should be able to invoke margin rights for that. This is being approached on a whole lot of fronts, which I applaud. Which of them will bear fruit? At the moment, importation is the easy way.
Right.
But it faces legal challenges wherever it's tried. Even if you get a couple of years of cheaper drugs before it's shut down.
It's a big benefit for those couple of years, 100%.
Right. Yeah.
Hey, I want to do a pivot. You talked about New Jersey revoking the tax exempt status for the Morristown Medical Center.
Yeah.
And in it, the judge wrote, quote, modern nonprofit hospitals are essentially legal fictions.
Yep.
And we have our major hospital system in Alaska is a nonprofit. We know that their profit is actually greater than the for-profit hospital in Anchorage. Yeah. But yet they don't pay property tax.
Yes, and this is a huge problem nationally. It's endemic. Everyone thinks, oh, nonprofit hospitals, they must be doing good and not making money. But basically, nonprofit just means they don't have shareholders. They can't show a profit. So instead, they show operating surpluses. And I think what's new in the last few years is they go out and do profitable things with those surpluses. They get into joint venture investments with drug companies. They build hospitals overseas that are for profit. The Cleveland Clinic built a hospital across from Buckingham Palace, a very fancy for-profit, private paying hospital. And when we asked them, how does this benefit the people of Cleveland? There really wasn't an answer, right? A thing that's really important to do. The Affordable Care Act made all hospitals disclose on the 990 form Schedule H what they do to earn their nonprofit status, which should be in terms of charity care and community benefit. And those listings are somewhat laughable. And they show the problem, though. The first thing that they list for community benefit is employment. And this is the catch-22 here, that hospitals in so many cities, and I don't know about Anchorage, have become major employers. They are a major political force. So it's very hard to say, okay, you're not really giving much to this community. You're doing a little bit of charity care, but hey, Apple computers, gives away some free computers, but they're not a charitable organization, and have them pay taxes. And then cities like Anchorage can use that money to actually help people get health care. That's such an obvious choice and such a politically difficult choice because of the power that different hospitals have in localities.
So I'm originally from Texas, from Houston. We have a large medical center there with many hospitals. Many of them are extraordinarily nice. They're like a five-star hotel inside. In fact, one has a grand piano in the lobby with a professional pianist playing music in the lobby. And I think part of the problem is that patients expect their hospital experience to be like a five-star hotel. You did write about this. And when we talk about some of these nonprofit hospitals in Alaska have some of the most beautiful buildings in Alaska.
Yeah. And this is part of the problem. They have these surpluses. They don't know what to do with them because they don't have shareholders. And so what do? They buy, they build, they invest in things that really don't help the community. And it makes me nuts when people say, oh, I love that hospital. There's this great coffee shop and it has the best coffee. Or there's free coffee in the lobby. And I'm like, ooh, that coffee ain't free.
And hardwood floors, and everybody has their own room. And there's just level of extra expense that does not improve the outcome. Yesterday, I was talking to my staff about some of my proposals, and one of them is to incentivize not doing this. And she was like, isn't there some data to support like having a really positive experience in the hospital as being good for your health? And I was like,
there are all these kind of bogus studies showing that having art or good views is better for your health. And sure, I'd prefer a private room. I know at my hospital here in New York, that's $1,200 a night. And I wouldn't like a private room for that amount. We still have some double rooms. So I think, yes, some of it is patient expectation. I did a story about a guy who went to Belgium for a hip replacement because he couldn't get one for a reasonable price in Seattle where he lived. So he went to Belgium. It was all-inclusive package. It was cheap. It was like $13,000. But he pulled up to the hospital and he was like, I can't go in there. It looks like a junior high school. And that's not bad. The Curie Institute in France, where I visited with a friend who was getting breast cancer treatment who lived there, it's very barren, but it's great care. And so what are we paying for? I keep saying to people who have money, why doesn't someone start like a Target of healthcare where you can just get no frills, but good medicine?
I love that. I love that. And when we have a public health clinic in Anchorage that basically does that, but I believe that they suffer from a stereotype that because they provide healthcare to everyone, that it must not be as good as the healthcare that you would get at a more exclusive clinic that only accepts these insurances. Or we have the new sort of concierge type medicine that just got legalized where you subscribe to a primary care clinic. They don't accept insurance at all. You have a monthly dues that you pay.
Yes, we have those in New York, of course. Yeah, it's very hard. And the sad thing is, the result of that is that in many areas, it's very hard to find a primary care doctor without those fees. There's a great shortage of primary care doctors because their services are undervalued and they're underpaid. And then, as you say, people want concierge care, fancy care. When I ask sometimes, what does concierge care buy you? And they say, someone will call you back in 24 hours. And I'm like, that should be the standard for everyone for free. It's just everything is monetized. And it's, how do we get away from that? It's a hard road, but the No Surprises Act, that's a
it's a good start.
The drug price negotiations and all the movement in the states, good start.
Can you explain in just simple language what the No Surprises Act currently requires?
Yeah. Again, I think it's great. It's really important, but it's a little bit holy in the sense that there are holes. And it in some ways puts the burden on the patient, even though that's the exact opposite of what it's supposed to do. So basically, what it says is if you get a bill, an emergency bill, or a bill where you had not consented to see an out of network provider, that is a surprise bill, and the patient should not have to pay it. The insurer and the provider should work out the price. The big exception to that, which maybe you can tell me why this happened, but I have my paranoid views, is that ground ambulance were exempt from that law. Um, Triply beware that ground ambulance, because it can give you a surprise bill, and most ground ambulances are out of network, including those of the local fire department, which always amuses or horrifies me. They put out fires for free, but if you need a trip to the hospital, that's $2,000.
One of the most stressful experiences in the urgent care is when I need to send someone to the ER and I know that they've driven themselves to the urgent care, and I know that the ambulance that should be called is possibly going to be an enormous expense for the patient. And so I'm in this dilemma where I need them to get to the ER. I believe they're going to need to be admitted, but I don't want them to have that fee. And so it's this where I'm literally struggling internally with, do I do what's going to prevent me from being sued at some point in the future? Or do I see if I can get this patient a ride? Can your wife come take you? Can we find a way to get you 8 minutes across town to the ER without having to employ this, what could be $1,000 or who knows how much, for them to come and just give you a ride?
Yeah. So that's a big problem. That to me is a hole that needs to be closed. And I don't know why it was allowed, but I suspect it had to do with ground ambulances are a big moneymaker for some municipalities. The other thing is, which I think seems unfair, is people have to recognize that something is a surprise bill, right? They have to know about the law and how it works. The law doesn't say providers, hospitals, or doctors can't send you the bill, right? You may not be responsible for it, but you're scared, right? You get a bill for $5,000 and it says past due,
collections will be notified. They're very scary. They're threatening bills.
So you have to know, wait, this is a surprise bill. I shouldn't have to pay it. And then depending on the state, you have to go through a surprise billing process that involves faxing things sometimes. And then the scary thing is, I think, you have to be careful that you haven't signed that little form at the beginning of the visit saying, I'll pay for something even if it's out of network. Because
so is that the whole, like if you signed like that iPad that was brought to you when your husband and you signed it, then that would give them permission to force you to pay the surprise bill?
It would give them an argument. And some of this is like, who has the spine to argue legally? Probably yes, they would be right that you sign this even if you didn't know it, and it's not a surprise bill. But I think, some of this is how much people dig in their heels, frankly, and stand strong against those, oh, we could send you to collection or third attempt to collect a bill.
As a journalist who's covered a lot of these cases of basically contested bills, what's the average amount of time that it takes somebody to resolve a case where they receive a bill that they shouldn't have received?
Oh, countless phone calls. And that's why the patients who we write about in our Bill of the Month project, I'm like, how do these people have all this time? You can't have a job?
Yeah, because you've been on hold. Wait, I'm sure you're connected to the wrong people. I'm sure it's very frustrating.
You're transferred around and you're told someone will call you back and no one calls you back. And so I think it's very hard. And the other thing that KFF data has found, which is really alarming, is because it's such an arduous process, only about 1% to 2% of people contest denials. It's yes, maybe if it's 30,000, you're going to say, I can't, we have to think about this. But if it's 1,000, maybe you'll say, okay, just put it on a payment plan. And terrible statistic, 40% of people under 34 have medical debt. I think it's starting out life that way with student loans and It's a pretty strict definition of what the No Surprises Act covers, but I think people are hit with surprises left and center.
Right.
Like, I thought that
Well,
was going to be cheap, and it ended up being not cheap.
do you have your book nearby?
Yeah, sure. I think I have a copy.
I would love if you could conclude just by reading the 10 economic rules of the dysfunctional medical market, because I think I will put them up on my wall in my office at the legislature, just so that I know what we're trying to fix. These are the 10 rules that make our medical system the way it is.
Okay, here we go. The economic rules of the dysfunctional medical market. 1, more treatment is always better. Default to the most expensive option. 2, a lifetime of treatment is preferable to a cure. 3, amenities and marketing matter more than good care. We've talked about that. 4, as technologies age, prices can rise rather than fall. 5, there's no free choice. Patients are stuck, and they're stuck buying American. 6, more competitors vying for business doesn't mean better prices. It can drive prices up, not down. That's called sticky pricing. Economies of scale don't translate to lower prices. With their market power, big providers can simply demand more. This one I love. There is no such thing as a fixed price for a procedure or test, and the uninsured pay the highest price of all. 9, there are no standards for billing. There's money to be made in billing for anything and everything. And finally, the kind of umbrella rule for our market is prices will rise to whatever the market will bear. And I will say right now, I think we're all reaching the breaking point, and so maybe there's something we can do about it.
I hope so. I can't thank you enough for your decades of work on this issue. I cannot recommend your book more to my listeners right now. On American Sickness, How Big Healthcare Became Big Business and How You Can Take It Back by Dr. Elisabeth Rosenthal. Big thanks for being on the show today.
Okay, thank you very much, and good luck making change in Alaska.
Thank you, listeners. If you like what you heard, please subscribe, rate, and review us. To contact me, email rep.andrew.gray@akleg.gov or call my office at 907-269-0123.